This lecture will cover Chapter 15, The Circulation of Blood, in the Human Body and Health and Disease textbook. During this lecture, we will discuss blood vessels, disorders of blood vessels, routes of circulation, hemodynamics, pulse, hypertension, and circulatory shock. The circulatory system was first documented in 16th century BC in an Egyptian medical document titled Eber's Papyrus. Physicians have been studying the circulatory system ever since, and interestingly, physicians followed an incorrect model of the circulatory system for about 1500 years. Galen, a Greek physician, identified the circulatory system as two one-way systems instead of one integrated circulatory system. There are three different types of blood vessels that we are going to discuss in this lecture, and the first are the arteries. Remember, arteries carry blood away from the heart and towards the capillaries. Veins carry blood toward the heart and away from the capillaries, and the capillaries carry blood from the arterioles to the venules. So arteries turn into arterioles, which turn into capillaries, which then turn into venules, then veins, and then back to the heart again. The arterial wall is made up of three layers. The most inner layer is referred to as the tunica intima, and it is composed of endothelial cells. The middle layer, which is the muscular layer, is referred to as the tunica media, and it is integral in the regulation of blood pressure and vasodilation and vasoconstriction. And then the outermost layer, the tunica externa or the tunica adventitia, is the outer fibrous layer of the artery. Now, we talked about how arteries turn into arterioles, which turn into capillaries, and as we progress and vessels branch into these various different vessels, they get smaller and smaller, and the capillaries are the smallest of them all. They have a vessel wall that is one cell layer thick, and they are so small that red blood cells have to move through them single file, and we will talk about why that is significant coming up. Now, veins are a little bit different than arteries because veins have valves, and while blood moves through the arteries because it is being pumped by the heart, blood moves through veins by skeletal muscle contraction. So if we're not moving our bodies, then our blood could be static in our veins. And so as we move, we kind of squeeze the blood back up to the heart. And in order to keep it from flowing backwards, veins have these valves inside them. They basically have the three same layers that arteries do, the tunica intima, the tunica media, and the tunica externa. However, their musculature is not as thick as the arteries because they do not have to sustain as much pressure from the beating of the heart. So we know that the job of the circulatory system is to move blood around, and in blood is nutrients and gases and waste products that need to either be distributed to tissues or picked up and excreted by the body. And so the circulatory system moves those components around in the blood. Arteries specifically carry blood away from the heart by pressure, right? And the capillaries are where the exchange of nutrients, wastes, fluids, gases, all of those things take place. And then veins collect that blood and return it back to the heart so that it can be reoxygenated. Here is an image of some common arteries, so it's a good idea that you get to know what they are. One way to review the different arteries is to use the Wiley anatomy drill, which is a really good tool, and it's located in the course content area. Here's an image of some of the most common veins, and again, Wiley anatomy drill is a good tool to review these. So we already said that the capillaries are where the exchange of nutrients and gases and waste take place. And the way that that happens is by differences in pressure. So if you think about the heart beating creates blood pressure, which is exerted on the walls of the arteries because they're closest to the heart. So the arteries are going to have a higher pressure than the veins. So when we think about systemic circulation and we go from arteries to arterioles and then we branch into capillaries, there is an arterial end to the capillary and a venous end to the capillary. And movement of wastes and water and gases in and out of the capillaries is based on those pressures. Two types of pressure, hydrostatic and osmotic. Hydrostatic basically means the pressure that's exerted on the wall of the vessels by the heart. So it makes sense that the arterial end of the capillary is going to have a higher hydrostatic pressure. What that means is there's more pressure inside the arterial part of the capillary, and that pressure is going to force stuff out of the capillary, out through the capillary wall and into the interstitial spaces so that it can be used in the cells. Stuff like oxygen and nutrients, glucose. Now the bigger components like salts and some proteins, they're going to stay in, but those smaller components are going to be pushed out on the arterial side. Now as we move to the venous side, the pressure is lower. It's actually lower inside than the water pressure, the osmotic pressure that's pushing in against the vessel. So what's going to happen is that's going to cause stuff from the interstitial spaces like waste gases and those types of things to move into the capillary on the venous end so that they can be carried away and excreted or discarded or metabolized or whatever the case may be. So we already talked about how there's more pressure on the arterial walls than on the venous walls. And because of that, arteries have to be able to withstand higher pressures and remain free from blockages. One condition that we talked about in a previous lecture about the heart is arteriosclerosis. Arteriosclerosis is hardening of the arteries caused by plaques or calcifications of fatty deposits on the walls. And so this gunk inside the vessel starts to build up over time, and it causes narrowing and hardening, inflexibility of the vessel wall. It impedes the flow of blood, and so this can be a serious condition where either we have to go in and clean out those plaques or put in some sort of stent or do some sort of bypass surgery, because what's going to happen over time is that there's going to be a restriction of blood flow, and that can cause death to the tissues beyond that obstruction. Here are a couple pictures of what these types of situations can cause if we have some sort of blockage in vessels or that cause ischemia and we're not getting the adequate oxygen supply and nutrient supply to the tissues. A lot of times this starts at the extremities because that's the furthest point from the heart. So it makes sense that those conditions are going to start at the furthest points and kind of work their way inward. And you can see this necrotic hand on the left, some gas gangrene on the right, which is also a product of some sort of bacterial infection, and anaerobic bacteria that doesn't like oxygen, can hide deep within the tissues, and then you get this sort of thing happening. This also happens in diabetics as well because there's a lot of sugar left in the blood that is not getting pulled into the cells because there's not enough insulin or the cells are insulin resistant. And so the cells at the extremities, the tissues start to die and necrose because of that. An example of a procedure that we can do if there is a blockage, say in a coronary artery, we can do something called a balloon angioplasty. And this basically gains access into the heart by the femoral artery, which is in the groin, and then passing up some wires, some different balloons, and then eventually putting in some sort of stent that will help to hold that vessel open. The balloon is going to serve the purpose of compressing those fatty plaques up against the wall, and then that stent will go in and lock in place and help hold that vessel open. And this is a procedure that typically occurs in the cardiac cath lab and not in the operating room itself. Some other disorders of arteries are aneurysms. An aneurysm is an abnormal widening of an arterial wall, and when that happens, it causes a weakening in the wall and increases the chance of rupture. A cerebral vascular accident or a stroke is something else that can occur caused by a thrombus or an embolism, and then that can lead to ischemia and then death. One example of a truly emergent situation in surgery is an abdominal aortic aneurysm, or what we refer to in the field as a AAA. And you can see the image on the left shows normal aorta, and then you can see this bulging area of the abdominal aorta right before that bifurcation. It traverses down through the thoracic cavity and the abdominal cavity, and just before it splits into the iliac arteries is a common place for an aneurysm. And on the right, you can see this big bulge is that aneurysm there. And then they have these little loops that are identifying other branches of the aorta kind of coming off. And how we fix this is we clamp above and below to get blood control, and then we'll open up that aneurysm. We'll sew in a graft above and below the aneurysm and do an abdominal aorta bifid bypass. So now let's talk about some disorders of veins. One disorder of veins that happens in individuals that stand on their feet a lot, like surge techs, is varicose veins or varices. So I would suggest compression stockings. That way, when you're standing on your feet all day, you still have some compressions on your legs, because what happens is, like I said before, the way blood gets back to our heart is by the movement of skeletal muscle, which squeezes the blood that's in our veins back up to our heart, essentially. But if we're standing in place and we're not moving, the blood in the vein starts to pool, and it can cause the vein to distend or widen. And as that happens, the valves don't close properly anymore. And so we get these distended areas these dilated areas, and that can be very painful over time. Another example of varicose veins in the rectum is hemorrhoids, which we can treat those surgically as well. And then thrombophlebitis is inflammation of the vein, and a lot of times it's accompanied by a clot and can result in a pulmonary embolism, which is fatal if that clot breaks free and goes floating through the circulatory system and then gets lodged in a pulmonary artery, can cause immediate death. There's a couple different surgical approaches for varicose veins, and that's what we're seeing the treatments here is for varicose veins. And this picture on the left, we're actually doing a vein stripping where we cut these little holes and literally just pull out the veins. They can also do a vein stripping of the saphenous vein and take out the entire saphenous vein as well. Other veins will take up the work of the saphenous vein, which I think is really amazing that the body can accommodate that way. And then the other type of treatment is with radiofrequency ablation. And so they'll run a little probe up the saphenous vein, and they use radiofrequency to seal the saphenous vein and to get rid of those varicose veins. For treatment of a hemorrhoidectomy, there's a couple different things we can do. So you can see the picture of the hemorrhoids on the left here. And one way we can treat these is by this special device that we insert into the rectum, and it staples, or sometimes it has a suture, and it will cut off the tissue and will seal or stitch or staple the wound closed. Something else we can do is we can do hemorrhoid banding, where we literally put these little rubber bands around the different hemorrhoids and or the varices, and that will eventually, in time, they will fall off and they can be treated that way. So when we talked about the heart, I mentioned the two different types of circulation, so systemic and pulmonary. Remember, systemic circulation carries blood throughout the body. So the path is from the left ventricle. Remember, that's the last place blood is in the heart before it leaves to go to the body. So from the left ventricle through the aorta, the arteries, the arterioles, capillaries, venules, vena cava, and then the right atrium. So that is going to be our systemic circulation. Pulmonary circulation, remember, deals with the lungs. So where was the blood right before it went to the lungs? It was in the right ventricle. So pulmonary circulation begins in the right ventricle, through the pulmonary arteries to the lungs, back to the heart through the pulmonary veins, and ending up in the left atrium. Should be a review. Here's an image to go with the words that we just looked at as far as blood flow through the circulatory system. Hepatic portal circulation is integral in helping the body maintain homeostasis. So when we're talking about hepatic portal circulation, this is a second filtering process that some of our blood goes through. So blood from the spleen, stomach, pancreas, gallbladder, and intestines, which is basically is carrying whatever we have ingested, is not going to go directly into the inferior vena cava. Instead, it is going to take a detour through the liver via the hepatic portal vein. So it's going to go to the liver, and it's going to pass through these capillary beds and venous spaces of the liver before it re-enters the systemic circulation and returns to the heart. So blood is going to travel to the liver, pass through those capillary beds, and then it is going to return to the inferior vena cava via the hepatic veins, and then it will be drained into the right atrium of the heart. Here I'm going to walk you through the process of fetal circulation. And what makes fetal circulation possible is 5 special adaptations. And so we're going to talk about each one of those. Those 5 adaptations are the umbilical vein, the ductus venosus, the foramen ovale, the ductus arteriosus, and the umbilical artery. So what happens when the fetus starts to develop is the placenta is attached to the wall of the uterus, and mom's blood is in there. And the capillaries of the baby, the fetus, insert themselves into the placenta. And coming off from the placenta is the umbilical cord. And the umbilical cord has umbilical vein and 2 umbilical arteries. And so blood is going to leave the placenta via the umbilical vein in the umbilical cord, and it is going to pass into the fetus's abdomen, and it is going to head towards the fetus's liver. There are different pressures at work here that cause this process to work really well for the fetus. There is very high resistance in the lungs, and there is very low resistance in the placenta. So that encourages a lot of blood to come back to the placenta. So as blood leaves the placenta, it goes into the baby, it heads to the baby's liver, through the umbilical vein, but when it gets to the liver, there is a little adaptation so that it can take a detour, and that detour is called the ductus venosus. And that ductus venosus is, let me see if I can circle it for you, is right here. So blood is coming up through here, and can either, blood is coming up through here, and it can either go to the liver, or it can take this little bypass route through the ductus venosus. Okay, and so some of the blood is going to take that little bypass route, and it is going to join with the blood coming from the inferior vena cava. So you have highly oxygenated blood and you have very low oxygenated blood, and those two are going to combine to form this mixed blood. All right, now as the blood heads towards the heart, it is going to come into the right atrium, and some of the blood is going to go down into the right ventricle. But because there is so much resistance in the lungs, right, there's these little millions of little air sacs called alveoli in the lungs, and those lungs aren't filled with air at this moment. They are filled with fluid, and that fluid causes a very high resistance. I'm going to try to write this here. Very high resistance in the lungs. So as some of the blood flows into the ventricle and is going to get pumped out of the pulmonary arteries towards the lungs here. It's going to go this way, right? But because there is so much resistance in the lungs, there's going to be a high resistance in the pulmonary arteries. That's going to back up into the right ventricle and into the right atrium. So there's a lot of pressure on the right side of the heart. That is where the foramen ovale comes in. So the foramen ovale is an opening right here between the right and left atrium, and some blood is going to be shunted over that way and into the left atrium. And from the left atrium, blood is going to flow down into the ventricle. Now, there's very little blood going to the lungs, so very little blood is going to be coming back this way into the atrium. All right, most of it's going to be shunted over from the right atrium into the left atrium and down into the ventricle. And then it's going to get squeezed into the aorta, right? And because there is so much pressure in this system here, and because of the resistance in the lungs, there's also going to be a lot of resistance or pressure in the pulmonary arteries. So our next little adaptation is going to be the ductus arteriosus. And the ductus arteriosus is here, and it is an opening between the pulmonary artery and the aorta. So these are kind of like these pressure release valves, if you will. So blood is going to be shunted from the pulmonary artery directly over to the aorta. And then from the aorta, the blood is going to make its way down the abdomen, and it's going to go into these iliac arteries here. And our last little adaptation is these umbilical arteries that come off from the iliacs. And this is where blood is going to return back to the placenta. And like I said before, there's a very low resistance in the placenta, but a very high resistance in the lungs. So blood from the fetus is going to be encouraged to return back to the mother, to the placenta, so that it can pick up more oxygen and more nutrients for the developing fetus. And that is fetal circulation. So what changes when baby is born? When the baby is born, the fetal blood vessels need to stop working. So when the newborn first breathes air, the pressure that is needed to fill the lungs with air on the first breath, if everything goes the way that it should close off that ductus arteriosus, the ductus venosus, and the foramen ovale. All of those things should close. If they don't, there can be, if the foramen ovale fails to close, that can create something called a ventricular septal defect, and that can create a lack of oxygen, and you can have a blue baby or a baby that is cyanotic. And if that occurs, then the baby would have to have surgery to correct that. Put simply, blood pressure is the pressure that is exerted on the wall of a blood vessel. So So pressure is going to be higher in the arteries and it's going to be lower in the veins. And this all works, again, because of pressures, right? There's a pressure gradient. High pressure in the arteries, very low pressure in the veins. This is what allows that blood to continue to circulate and liquids flow from high areas of pressure to low areas of pressure. Then when we have a crisis where there's little or no blood pressure, that becomes fatal if it's not reversed. And similarly, hypertension or very high blood pressure can cause critical situations where we could get an aneurysm, and eventually that could lead to a rupture in the vessel. Here is an image to remind us that pressure is what drives systemic circulation. And if we're starting at the heart with this systolic and diastolic pressure seen up here, right? So this is the contraction of the heart. And as that blood flows through the heart, the aorta, the arterioles, and gets to the capillaries, we see a significant reduction in pressure, about 35 millimeters mercury on the arterial side of the capillary, and then as we move away from the arteries to the vena cava, here we have a pressure of about 1 millimeter of mercury. So, if there's an increased amount of pressure on the venous side, that is going to cause critical situations in the arterial side and vice versa. So what are some factors that can influence blood pressure? One is blood volume. If we have more volume, we're going to have more pressure. There's going to be more pressure exerted on the vessel walls. If we have less volume, there's going to be less pressure exerted on the vessel walls. The strength of the heart contraction can impact cardiac output. A stronger heartbeat increases the pressure, a weaker beat decreases the pressure. Heart rate. An increased heart rate increases the pressure, and a decreased rate is going to decrease the pressure. The thickness of the blood or the blood's viscosity can also have an impact on pressure. If blood is thinner or less viscous than normal, that is going to decrease the pressure. And if the blood is thicker or more viscous than normal, then that is going to increase the pressure that's exerted on the vessel walls. Also, any narrowing or any blockage is going to increase pressure on the vessel walls as well. And here's just a visual of decreased resistance versus increased resistance. I kind of think of this as a hose. If you have a certain flow through a hose, and then you decrease the size of the hose, and then you decrease the size of the hose again, you're going to increase the flow or increase the pressure that's exerted on the hose, or in this case, on the walls of the vessel. So even though we say blood pressure, perfect blood pressure is 120/80, it does vary within a normal range from time to time and from person to person. One thing that we want to think about that can affect arterial blood pressure is central venous pressure. So central venous pressure represents the low end of the pressure gradient. Remember, we said it's about a 1 millimeter of mercury as opposed to the 120 millimeters of mercury at the aorta. So if let's say the heart is working the way that it should, then central venous pressure is going to be low. However, if the heart isn't working like it should, blood is not going to be moving out of the heart like it should, and that is going to cause a backup of blood, which is going to exert more pressure on the venous system. So some venous return of the blood depends on 5 mechanisms that are mentioned in the book. One is a strongly beating heart. If the heart is working properly and adequately, then we're going to have low venous pressure, which is good. An adequate arterial blood pressure is going to be key. The valves in the veins, are they working adequately and are they functioning properly? The pumping action of skeletal muscle as they contract. Again, that's why it's important for us to get up, move around, and do some exercise. And then lastly, changing pressures in the chest cavity caused by breathing. We already talked about the thoracic cavity being a closed system, and as we breathe, that causes pressure changes, which can impact pressures. So a medical term that we need to be familiar with is the pulse, and that is defined as the alternate expansion and recoil of the blood vessel wall. And we tested our carotid pulse a little while ago, so we know what a pulse is supposed to feel like. Here are some of the most common pulse points. Up here at the very top, starting with the temporal artery, and then the facial artery, moving down to the carotid artery, brachial artery, which is how we get a pulse on a baby, more up near the axilla, radial artery down on the thumb side, femoral artery there, posterior or the popliteal artery, which is in the posterior knee, the posterior tibial artery, and the dorsalis pedis. So those are some pulse points. When blood pressure exceeds 140/90 millimeters of mercury, then we have a diagnosis of hypertension. 90% of hypertension cases are primary essential, which means we don't know why it happens, 90%. Secondary hypertension can be caused by other conditions such as kidney disease. And then risk factors associated with hypertension include genetics, age, stress, obesity, and several other factors in there. And if it goes untreated, it can contribute to heart disease, heart failure, kidney failure, and other types of problems. Here is a chart that is provided in your textbook regarding blood pressure classification. So you can see normal is 120/80 or around there. Pre-hypertension, when we're approaching 139/89, and then stage 1 and stage 2 hypertension. You can see those measurements there as well. So coming into the home stretch here, we're going to talk about some different types of circulatory shock. Circulatory shock refers to the failure of the circulatory system to adequately deliver oxygen to the tissues, which can result in damage to our cells. So the first type that the book talks about is cardiogenic shock, which results from any type of heart failure. So this could be a heart attack, different types of infections, or other heart conditions. Cardiogenic literally it means produced by the heart. So in this case, the heart can no longer function properly and blood flow is significantly decreased or stops altogether. So hypovolemic shock results from the loss of blood volume in the blood vessels. So here we're talking about volume. Hypovolemia means condition of low blood volume. So reduced volume is going to result in low pressure. It's going to result in low flow of blood to our tissues, which means our cells are not going to be getting the oxygen and the nutrients that they need. Hemorrhage is a common cause. Burns could be another one because that's increased loss of interstitial fluid due to burns. Can also cause blood plasma to drain out of the vessels and go into the fluids, into the interstitial spaces, because we're trying to replace those fluids. Loss of interstitial fluid is common in situations where there is chronic diarrhea and vomiting, dehydration, perhaps an intestinal blockage, severe burns, like I mentioned, and other conditions. Neurogenic shock results from widespread dilation of blood vessels, and this can lead to an imbalance in autonomic stimulation of smooth muscle in the vessel walls. Neurogenic means produced by the nerves. So this occurs when sympathetic stimulation is disrupted and there is a lack of muscle tone in the vessels. So now we can't maintain pressure, and so pressure is going to be decreased. That means the flow is going to be decreased, flow of blood to our tissues. Some situations that might cause this is injury to the spinal cord or the medulla oblongata. Different types of pharmaceuticals that depress the nervous system. Emotional stress can also be a causal factor as well. Anaphylactic shock results from an acute allergic reaction called anaphylaxis. It causes the same kind of blood vessel dilation that occurs in neurogenic shock. And you can see some in this picture here, some pathophysiology of anaphylactic shock, swelling, hives, itching, redness, respiratory distress, GI distress, and central nervous system distress. Lastly is septic shock. Septic shock typically results from complications due to septicemia, which means a systemic infection in the blood. What happens is whatever microorganism is in the blood is releasing toxins, and those toxins lead to septic shock. They also dilate blood vessels, so similar to neurogenic shock and anaphylactic shock, like we talked about before. One example of septic shock you might have heard of is toxic shock syndrome, or TSS, which can result from a staph infection that begins in the vagina, and commonly it can result from leaving tampons in too long. And that's why there's instructions on the package that says to change tampons every so often, because bacteria can stay in there, and it can lead to toxic shock syndrome, which causes septicemia. This concludes our review of Chapter 15, Circulation of Blood. I hope that this lecture was helpful, and thank you for listening.